Thoracic spine HVT is a very common osteopathic technique, particularly this anterior-posterior setup for the technique. I particularly like this HVT, and it's something I use very commonly in my patients. It's not particularly forceful. It doesn't put a lot of stress on the patient's system. It has a good systemic effect in terms of relaxing the patient, giving them a sense of improved range of motion. I don't like to target this technique as something that is solving somatic dysfunction, or I don't really prescribe this kind of theory of specific biomechanical lesions. I see the effect of HVT as something much more systemic, and some research supports that idea in terms of its impact on descending modulation from certain areas, higher centers in the brain, and their impact on the spinal cord, potentially release of some hormones in the body that influence sense of comfort, relaxation, and those kind of components. So I take a general approach. That doesn't mean that I do the HVT in a general way. I like to be as specific as possible in my application because I believe this maximizes comfort for the patient, maximizes efficacy. You want to always avoid a nocebo effect, so try and remove those contextual factors that can create a negative impact for the treatment. So from that perspective, we try and be as specific as possible when setting up the technique and making it optimizing the individual HVT setup for the patient. In the setup, I also like to basically HVT the full thoracic spine, top to bottom, when I can in any given patient. That's not always possible, and sometimes it's safer and better to localize the HVT to one area or another. But we'll look at the different variations that optimize the technique for the typical thoracic spine segments, and then additional variations for junctional regions like the CT junction and the TL junction, or at least the lower thoracic vertebrae. The fundamental of the technique is that we're going to be applying force anterior and posterior through the thoracic spine. That pressure applied through the sternum with a block provided by my hand underneath the thoracic spine creates a gapping at the thoracic facets. In most cases, it doesn't cause any trouble for the patient to apply pressure through the arms like this. However, when we apply pressure on the chest, there is an axial load along the humerus into the shoulder. And where possible, I want to avoid any stress on the shoulder joints. That's why adding a towel or some other support under the elbows gives a more direct contact from my force on the elbows through the sternum to the thoracic spine, negating any pressure through the shoulder joints here. From here, we have to then think about how I'm going to apply that force to the thoracic spine. I generally apply my upper abdomen, so I let the olecranon processes rest just under my xiphoid process. This means that I need to approach the plinth at 45 degrees in order to get my body in the correct position. The plinth height is essential here to have a comfortable position but still be able to apply the appropriate pressure to the spine. So after I have set up the shoulders in the appropriate way for the patient, I then place the towel in position. Next step is to put my body in the correct position, and I really have to make sure that the plinth height and my body positioning are 100% correct before proceeding with the rest of the technique. I usually bring the rest of the towel over the elbows here to give some further cushioning and separation between me and the patient. I apply the contact with my abdomen here, and this is the point at which I check. Can I comfortably apply pressure through here? Am I comfortable as a practitioner? Can I move my arms freely from this point? Once I'm happy with this setup, the next step is to make sure that I can get my hand correctly under the thoracic spine to provide that counter force to the pressure I apply with my body here. There are a number of different ways of doing that, but the most basic way to start with is to roll the patient towards you, exposing their spine so that you can put your hand in the correct position, then rolling the patient back over your hand and applying the thrust at that point. To do this, it's usually better to bend the knee on the opposite side. I can then take one hand to the pelvis here, just reaching towards the SI joint with my fingers, and the other forearm along the thoracic spine. My own body creates a block for the patient so they don't go too far. From this position, I'm then just going to support under the thoracic spine with my forearm, and I can use a number of different ways just to test for the correct location and get a feel for the movement of the thoracic spine. So what I'm doing here is just gently flexing and extending the thoracic spine with my right hand and my abdomen while palpating the interspinous segments. Additionally, or an alternative would be to lift the patient's head and move the thoracic spine using the patient's head. This also helps me locate the CT junction through the movement of C6 anteriorly when I extend the cervical spine. Once I'm happy with the location and the movement, I can apply either a flat hand contact or the pistol grip to block the movement of the thoracic transverse processes, with the spinous processes sitting in the center of my hand. So I place my hand in the correct position, whether flat hand or pistol grip, cover the elbows here, and then roll the patient back into position, keeping my hand in place centrally on the thoracic spine. I can then ask them to straighten their leg, so if you relax your leg down again, and from here I can control the elbows in a variety of ways. I can either use my forearm across the elbows here, or the palm of my hand here. This gives me some leverage to flex or extend the thoracic spine to some extent to optimize the locking before applying a short, sharp thrust directly through the plinth. Once I'm happy with the level of locking I've achieved, I simply drop my weight through the patient. This can be done in combination with the patient's breathing, so asking the patient to breathe in, and as they breathe out, at the end of the out breath, applying the thrust at that point.